Yeah, good morning to all. Basically, my topic was mainly for the residents that whenever they get a chance to see at the topographic graphs, there are certain basic things which they need to understand before they can go on to the diagnosis of this topography. So if we look at the cornea, basically the topography means we are looking at the shape. We are looking at the shape of the cornea, and we know cornea is the most powerful surface, contributing about 70% of the total eye power. If we look at the surface, this photograph shows that how the three different shapes can be there. One basic is a spherical, where the radius of curvature is same in all the axes. So that is how it becomes a sphere and it produces spherical errors. Prolate surface means where the power is more in the center. When we go towards the periphery, the power goes down. So that is a prolate. So cornea is normally a prolate surface. The oblate surface becomes when post-LASIK patients, when after this LASIK, the power of the cornea in the center goes down. In the periphery, it is little more. So that is what a oblate surface. Normally, we know the radius of curvature of the interior surface is 7.8 and posterior 6.5. The average thickness of the cornea is 520 microns. And why it is important to have topography or the study of the cornea? Because even a small abrasion on the cornea can lead to a lot of visual disturbances. For the purpose of study, the cornea we know has been divided into different zones. The central apical zone or optical zone is around 4 millimeters. Somehow this pointer doesn't show here on the screen, but you can look at the slides. The central is a 4 millimeter, which is a optical zone. And then we have a paracentral area, which is from 4 millimeter onward up to 8 millimeters. Then peripheral cornea and a limbal area. So this is how the topography graph will come, that you are whether looking at the central part or the paracentral part or the peripheral part of the ear. Now to look at the corneal study, there are a number of devices available. Placido is a basic structure which is available in the OPD, and one can see whether the cornea is having a regular astigmatism or abnormal. Then there are elevation-based tools which give us the elevation profile of the cornea. Some are based on the like OCT on the interferometry. Then there is raster stereography, and ultimately main topic I will be discussing about the Scheimpflug imaging. Now Placido disc, we know it's a basic structure. It is consists of white and black zones, and there is a central hole through which the observer has to look at the cornea, and then one has to see how are the rings looking. The more closer rings means the steeper cornea, and more wide away, far away rings means that's a flat part of the cornea. So this is device which is available in OPDs, and it's very easy to use, and it gives us a clue whether we should go for further topography or not. Then manual keratometry, everybody have been using long times back. The Boschian Lom is a type which was used. It studies about 3 millimeters of the central cornea. The only problem is that we are just looking at the anterior surface of the cornea. The posterior surface is not scanned with this, and it acts like a convex mirror. Then there is a photokratoscopy. It also has the rings, black and white rings. The advantage is that there is a camera attached which takes the photo, and computer will analyze how is the anterior surface through this photokratoscopy. Then there are video based also. Scan, it uses a slit scan photography, and about 40 slit scans are taken. The advantage is that it takes both anterior and the posterior corneal curvature. Now somehow with the coming up of the pentacam and other devices, this is now not much used. Now coming basically to Scheimpflug imaging, which is very important these days. Before any LASIK procedure, every patient has to undergo Scheimpflug images. So 3 different devices are available. There may be much more also, but I know these commonly available devices like Pentacam, the Cirrus Plus also, and a Galilei. So these are the ones who are going to look at the anterior as well as the posterior corneal surface. These devices take about 25 to 75 sections of the cornea, and then they reconstruct these images and will calculate all the parameters of the cornea right from limbus to limbus. Now to interpret those images, we have to look at 3 basic you can say parameters. One is the curvature. The curvature of the cornea means that topography is going to give us clue about how is the surface curvature of the cornea. Then we are going to look at the elevation, whether in the surface there is any abnormal elevation in the anterior or in the posterior surface of the cornea. And third, important parameter is a pachymetry, means the thickness of the cornea. So this topography is going to give us whole profile of the cornea, that how is the pachymetry changing from the center towards the periphery. So all other devices were just seeing at the optical zone or the central zone. Now once you are through the topography, normally these are the four graphs which you are getting. Before we analyze, one must be sure that you are looking at the patient which is there with you, that name, age and date of birth and all is first confirmed. And then important is to check the eye also which is under scan, because lot of abnormalities can be there which are unilateral. Like sometimes the patient with keratoconus may have just involvement of one eye, the other eye may look normal. So before you tell the patient that you have keratoconus or some other corneal abnormality, important to have a look at the eye, which eye you are looking at. Then these graphs are color coded. So green colors means the data is almost near normal. Then red means you are looking at the steeper areas, and blue ones are the flatter areas. So these four graphs basically axial scan, the thickness map, the anterior elevation and the posterior elevation. And all the figures are available in the center where you can see how much is the pachymetry, how much is the keratometry in a particular patient. Now these are four display maps I just said. So one is the axial map, which measures the axial radius of the cornea. Then sometime we can use the tangential map also, which basically measures the tangential power in relation to the neighboring points. So this highlights elevations more clearly than the axial map. Then there is a pachymetry map which measures the thickness of the cornea, then anterior and posterior elevations. So if there are abnormal areas like in keratoconus, you are seeing abnormal elevation in the cornea, so that also can be picked up by the anterior elevation and the posterior elevation. So then you have to see whether they are falling within the normal range or abnormal range. So sometime, normally we use 4 graphs, but there can be 6 graphs also. So one can include, depending upon your choice, you can have the another like axial, tangential, the pachymetry, and the anterior elevation and the posterior elevation, and along with the keratoscopy. Not only this topography of the cornea is going to tell us about the corneal parameters. In addition to this, the topography gives us white to white also, and also we can measure angle kappa, which is important for surgical point of view, and also it is going to tell us which is the thinnest point of the cornea, and the angle measurement. So angle of the anterior chamber can also be measured by using the topography. And some of the machines, they have a lens status also, where you can do the densometry of the lens also. Now this graph shows like the even the some of the topographers give us that intracorneal ring segment report also. Like depending upon the cornea, like you have a steeper cornea in the center, so they are going to tell us that which area you need to put a intracorneal ring segment. And then high order abrasion graph is also available, which can be seen whether the patient has any high order abrasions or not. Then once you are going through the graphs, then certain indices will come. So it is important to understand these indices also. Like there is a SIMK, which tells us about the axial power of the cornea, the K1 and K2. Then there is a SRI, surface regularity index, which measures any irregularity in the center of the cornea using 4.5 millimeter area. So any irregularities or asymmetry in the cornea can be picked up looking at the SRI. Then SAI, which is a surface asymmetry index. Basically it looks at the power of the cornea above and below. Means 180 degrees away, so you can see like in keratoconus, the lower part may have more power than the upper part. So normally the difference may be just 0.5 diopters, but if you are seeing higher difference in the upper and the lower part, it means the patient has some abnormal elevations. Then asphericity, this is very important for again lens point of view, that Q value, that how the corneal power is changing from the center towards the periphery. So that is calculated as Q power. So normally one has a Q power of about 0.26, means the central cornea has more power. As we move towards the periphery, the corneal power goes down. Some more indices. One very important index is a Balin-Ambrosio enhanced ectasia. So this helps us to diagnose patients of keratoconus, because this gives us some enhancement using 2 different graphs, and then the difference between the basic and the special graph. So if there is a red areas, that will indicate that patient has a keratoconus. Then we look at the scan here, like the graph here, you can see it is going down. So that is a pachymetry progression index. So normally it falls within the standard deviation here, but if it is going down, it means there is some abnormality. That percentage of the cornea, as it has to change normally from the center towards the periphery, it is more faster. So that is how you get this graph. So this is how you look at the Bailyn-Ambrosio graph. Like here you can see the red area showing the anterior elevation and the posterior elevation. And this is how basically using a best fit sphere it is calculated. So two different mechanisms are used. In one you exclude the central 4 millimeter zone, and in the one you include the 4 millimeter zone and see the difference between the two. So the more elevation will be picked up by using the Bailyn-Ambrosio scan. So diagnosis of keratoconus, one can make by inferior stiffening, showing the cone showing increased power with the surrounding flattening. Inferior superior asymmetry will be there. Then there will be skew of axis. Normally there is a 90-degree difference between the steeper and the flatter meridian. But here if you see the axis is not within the 90-degree, there is a skewing of the deviation. Then KPI can be checked whether keratometry predictability index is there. Then KISA, it's a score that if it is more than 60%, it tells us about the suspicion of the keratoconus. So this is one patient showing a classical keratoconus. You can see, look at the Kmax value, that how much is the Kmax in this patient, like 50, 57, 56. And then also look at the thickness map, which tells us that thinnest part of the cornea, and then as you move towards the periphery, the thickness of the cornea increases. Then anterior elevation, if it is within the range, it will not be showing as a red, but if it is more, it will be shown as a red. So you can diagnose keratoconus from the graphs. So basically, the topography we are using mainly for two purposes. One is the diagnosis of keratoconus or abnormal elevations, like sometimes you get patients of pellucid marginal degenerations and post-LASIK ectasia. So that has also become very important these days. Patient has undergone LASIK and then suddenly presents with the ectasia. So it is important from that point of view also. And another important point for topography is patient who wants to undergo LASIK or any corrective procedures. So all patients must undergo topography so that you can see any abnormality in the cornea before you advise them to undergo any kind of a refractive surgery procedure. Thank you very much.